So I'll go back to these 4 publications that we are to discuss, and you realize that I've tried to club these publications into the 2 sublobar resection ones. One was the ground glass opacities, which Sarvana discussed, and the other one was the lobar versus sublobar resection for peripheral stage 1A tumors. The second one was neoadjuvant therapy or a peri-operative therapy with immunotherapy and chemotherapy combination, and the third one was describing the recurrences. A lot of has been already been covered. I'll try not to go into more onto the publication part of it, but more into how we are seeing from an Indian perspective and what all we can take back from these studies. So I'll start with this publication which Dr. Ralong discussed. So this was a non-inferiority trial for sublobar versus lobectomy for peripheral T1A disease. How many of us actually see these T1 diseases? See, we have Virendra here, who's from TMH, probably one of the high volume centers from the western part of countries. Darlong sir is here, he's from Rajiv Gandhi, again a high volume center. Sarvana is doing a lot of thoracic bursts. But how many of us actually see these T1 diseases? You know, we are discussing these publications. Look at the tumor size. 90% of their tumors were between 1 and 2 centimeters. 10% of their tumors were actually less than 1 centimeter. So I will start with Virendra. High volume center, TMH, lot of patients coming.
No, still it is a very rare phenomenon to see an T1 N0 disease in our practice also. If you see early, definition wise, it is around 5%, that is what we operate. And in that T1A N0, I think it's rare. But what I want to say is, it's a challenge that they have given us. We need to find such cases and we need to treat such cases. So there are ways to find what Dr. Darlong had mentioned in his one of the slide, screening. So we have to come up with the strategies to find such tumors and then follow their treatment protocols so that we can achieve such a wonderful survival. That is what we need to aim for.
Sarvana, T1 disease.
Yeah, T1 disease, actually we had a spike during COVID. So during COVID we had around, we don't know much, from the number of segmentectomies I'll tell you. So 2020 we did around 12, 2021 we did around 6, 2022 we did around 2, and this year December ho gaya, ek hi hua. So I think
would prefer a SBR over.
Virendra, what is this you guys do?
So if patient is fit for general anesthesia, I think we can instant.
No, I'm talking about borderline.
Borderline, we are giving them. So I don't think
if anesthesia is ready.
Yes. Wedge is going to affect his PFPs, man. I don't think so.
Anybody doing a wide wedge for this?
Accidental wide wedges. Accidental wide wedges where there was a biopsy was not possible and they ended up with a wedge with somewhere else, and now it has come.
Because the only reason why you would do a sublobar resection in such a borderline patient high risk is the tissue. I think and safety is very important. So I think anybody doing wide wedges as a
all segments are not simple, but you were saying some of the segments are easy, vessel segments are very difficult. So if you need tissue, why not do a wide wedge in a vessel segment with a good margin?
Go to the United States, around 30% of high volume thoracic surgeons practices wedges. They don't even do a biopsy in those cases.
That is why the calcium trial, almost majority of them are wedges.
They had to include wedges because otherwise they won't get them. So if you go there, you will be surprised to see that even 3 centimeter lesions, they are not sending them for a serial biopsy or a bronchoscopic biopsy. They are just doing a medicine. Yeah, Germany also.
But the concept for a wedge is that you have to ensure that your margin is almost equal to the size of the tumor, which you have to ensure so that you don't end up with huge margin to fall. This is the last part of it, and this is where we actually will hand over it to the medical oncologist because the subsequent topics are all medical oncology. So the keynote 671, which Dia talked about, although she touched upon it, but I want Virendra to tell us how does neoadjuvant IO help surgeons? How does it help us?
So there is a significant downstream. Whatever trials we have so far, there is a good pathological complete response or major pathological response. A bulky tumor, it is difficult to go in and operate. If the size has decreased drastically, it is easier to handle the tumor. Another thing is that what I think the spectrum of surgery is increasing with neoadjuvant immunotherapy. If you see Nadeem trial or this trial where they have included N2 disease, 3P also. So those kind of where we sit in JC and say that multi-station N2 is N4 CTRT. Maybe with neoadjuvant, even if there is a significant downstaging, those patients can also come for surgical things. Yes, there is a little bit of surgical challenge, but we all are learning and I think will improve.
Other than the surgical part,
I'll give you a pointer. Just last week we had a case referred by a prominent medical oncologist, gave neoadjuvant immunotherapy and chemotherapy, and now for downstaging patient had single station N2. I did the lobectomy. I was just not able to access the subperitoneal station. It was just impossible to go there without damaging the kidney. So we are going to have now. I just took the tissue there and sent for frozen. It was negative. So yeah, I'm lucky. So the thing is, surgery is going to become more and more difficult with more and more immunos coming in, and surgeons have to get ready for this situation. Although it may be good for the patient.
it is actually good.
And the latest literature is also coming in, like what Virendra said, that now studies are coming in which show that multi-station but not bulky N2 disease might really benefit from surgery, especially post-neoadjuvant immunotherapy. So I think a larger subset of patients will be able to offer surgery and curative options where we were left for CTRT.
So bulky I'm not very
No,
sure.
no, I'm saying multi-station, non-bulky.
Yeah, multi-station non-bulky is still acceptable, but bulky, like what Sarvana mentioned, the nodes get really sticky. We'll come to that. So it is not just that you are expecting tumor downstaging. See, most of the studies that have been done, they have been done in resectable tumors, and we are talking about not making surgery easy for us, but making the patient survive longer. See, you have to realize what neoadjuvant chemo did for breast cancer was it didn't make them more operable. MRMs were always possible. It was just it made the patients live longer, which provided us walking advertisements for breast cancer surgery. And this is what is missing for lung cancer, and this is what we are hoping that neoadjuvant immuno will do for us, that our patients will live longer. We'll have 100 patient survivor groups, which are hardly 10 patients right now, because we want to see patients living longer. So it is not just tumor downstaging, but also allowing better selection of patients, getting more PCRs, and eventually making patients live longer is what I look forward to neoadjuvant. The cons is what Sarvana mentioned. These were the outcomes, and you see actually that the PCR rates were as almost triple of what were seen in the placebo arm with pembrolizumab. The question is that is perioperative immunotherapy is it increasing resectability? Priya, there was a question in your slide, will it make inoperable disease operable?
Yeah.
You think it will make inoperable disease operable?
Unresectable disease.
Not.
Difference is there.
Yeah. So that is why the question is that neoadjuvant therapy, it leads to fibrosis, it leads to nodes getting more and more stickier, especially if they are around the pulmonary vessels, the veins. The tissue might become more fragile, and therefore, like Sarvana mentioned, lung resection may become even more challenging. But IO is everywhere. We just saw one of the trials which Priya mentioned, the Keynote 671. There are more funny acronyms and more difficult names to pronounce. Checkmate, AGM, IM powered 030, some of those. And it is not just in the perioperative ones, there are more and more trials in the adjuvant setting also, where they are offering these drugs, nivolumab, durvalumab, atezolizumab, and pembrolizumab. I think we'll end the panel here. Thank you so much.